So shall we start with really this issue of the overuse of antibiotics? And Alison, perhaps you'd like to start, because you kind of gave quite a good exposition of that this morning.
Thanks very much, Kathy. Just as a general principle, we are in a global crisis with antibiotic resistance. And I think we need to be very, very mindful that any time we give an antibiotic, it has to be for a jolly good reason, in the appropriate dose, and for as short a time as possible that is appropriate. So from a resistance point of view, the whole, if we didn't have antibiotics, there would be no antibiotic resistance. And although part of the problem with antibiotics is that they're in the food chain, and we can't do anything about that, there are practices that we can do everything about, and it is everybody's problem. It's the midwife's problem, it's the junior doctor's problem, it's the microbiologist's problem, it's the pharmacist's problem, it's my problem. It's not just someone else's problem. And it's also the user's problem. So everybody who is going to be given an antibiotic needs to be cognizant of the fact that they will change their floral pattern if they have an antibiotic. And our other organ, you know, we have liver, kidneys, all that sort of thing, we have more bacteria sitting in our colon than we have human cells in the rest of the body. And for most of us, we live in a little sort of symbiotic relationship with our fecal flora, and our fecal flora keeps us immunologically healthy. And we know that people who have poor immune health often have abnormal bacteria. We know obesity is associated with abnormal bacteria. If you put obese mice's feces into thin mice, they get obese, and vice versa. We know that irritable bowel syndrome is mended by fecal transplants from someone who doesn't have fecal bowel syndrome, so, who have irritable bowel syndrome. So we are desperately dependent on our fecal flora for immune health, and that is another reason we have got to be very, very, very careful about using antibiotics unnecessarily. However, antibiotics are and can be life-saving, and they are life-saving in infection, in established infection, and they can be life-saving for babies when the mother is at risk of transmitting group B strep. So for me, it's all about judicious use. I think for the child, I just want to reiterate the sort of the clean child hypothesis, as it's sometimes called, although it's more complex than that, dictates that immune health in children is heavily driven by maternal fecal flora. If we abnormalise maternal fecal flora, we will abnormalise the development of the naive immune system, and we have to be very, very cognizant of that, because there's increasing data to support that. So the principles must be that we have jolly good reason for using antibiotics that are targeted at the right individuals. And for me, I think giving mothers antibiotics because they might have something that we should give antibiotics is simply not good enough in this era. We have other tools. We hear about PCR, for example, as well as culture-based methods. I think we've got to get a lot more clever than this. So I'll shut up at that.
Thank you, Alison. So just before I bring in Dr. Rao, can I ask the obstetricians on the panel, in that case, if there's a positive move towards introducing more antibiotics for GBS, should we be changing some other guidelines? I mean, what about routine antibiotic prophylaxis for caesarean sections? I mean, is this a case of trying to make the guidelines work more together?
Caesarean section infection rates, frequently they are superficial infections and not deep infections, they're superficial infections. And they're present frequently some days after the operation. So we're not really differentiating between intraoperative acquisition of the infection and the postoperative acquisition. And the midwives follow up the mothers for up to 10 days after the procedure. Now, For all the cesarean section prophylaxis, which is pretty much every hospital now complies with it, and you're taken to task if you don't, I have not seen a corresponding fall in the cesarean section infection rates. Because the prophylaxis acts only for the intraoperative infection rates. Subsequent to that, I think recent study that was done by Public Health England, and I don't know some of your colleagues from Public Health England may be able to comment better on that, but this was a study that was done and by Jenny Wilson and others, which showed that the consistent rate of infection was 10%. Now 10% is an awful lot of infection, but most of it is superficial. Most of them is post-discharge infection. So I take your point. If you were leading up to saying whether it's useful or not, I'll be a little skeptical about whether it's useful or not.
Okay, well, thank you very much for that. Because I mustn't draw us down a different issue, which is, cesarean sections. But I suppose my point is really, do the guidelines need to tie up more? Because we've heard today all about, this issue of harm, and could we minimise the harm of routinely screening for GBS by changing what we do in other areas? Andrew, what do you think? Should the RCOG be looking more broadly across its guidelines?
I suspect obstetricians and midwives, the practice of obstetricians and midwives is heavily influenced by the triennial confidential inquiries reports. I was explaining to Jane earlier about one of our guidelines, it's number 37A, it's thromboprophylaxis, is an incredibly complicated and very difficult guideline with lots and lots and lots of pages of risk factor assessment, and yet that particular guideline was credited with reducing the number of maternal deaths in the United Kingdom from thromboembolic disease. So the confidential inquiries certainly influence our practice. The last 2 or 3 inquiries have highlighted sepsis as being a main cause of maternal death, and that's why I think whilst it is our concern, it's everyone's concern about our long-term flora and fauna in our bowels. When we're actually working on labour ward or we see someone with a suspected urinary tract infection in an outpatient department, I suspect that's why they're given antibiotics, because it's in the front of our mind that sepsis can be life-threatening in pregnancy.
Thank you, Andrew.
Something that GBSS has promoted ever since it was formed is actually trying to stop the unnecessary administration of antibiotics. And, I would agree with everyone. I think when a woman was admitted with a bit of dysuria with no temperature and no other symptoms and had been started on antibiotics, I used to have a little bet with the SHO that the culture would come back negative, and I used to win 9 times out of 10. So there are areas that we could all draw back, and we've spent a lot of time stopping obstetricians giving repeated courses of antibiotics during pregnancy. Even some well-known obstetricians have phoned me up and said, I've had somebody who lost a baby and I'm going to give her antibiotics every fortnight for 10, and all this sort of stuff. The issue then arises as to what is the alternative. We're not talking here about using prolonged courses of broad-spectrum antibiotics. We need to remember that in terms of upsetting the flora, we're using an antibiotic which is the longest one we've ever had, more than 60 years of penicillin. It's very narrow spectrum. We know a lot about it. Most organisms that would have become resistant are already resistant. It's given for a short period of time. Now, as we've heard, there may be some short-term effects on the microbiome, although in the longer term, up to a year, there don't seem to be any. But that doesn't mean to say that giving 20% of women penicillin is something that we're pleased about. If it was possible to determine which strains of GBS were more pathogenic, so we've already heard that is something we should explore, so that we could restrict giving it the antibiotics to those women who carry those pathogenic strains, a bit like human papillomaviruses and CIN, for example. We know which ones cause the trouble. That would be great. If we can have a vaccine that works, that would be great. The issue for us at the moment is that at the present time, the risk factor approach seems to be resulting in lots of women getting antibiotics, which in fact are not necessary because the woman is not a group B strep carrier, and a lot of women who are carriers, whose babies end up getting early onset, are not getting it. And actually those two are relatively balanced. The numbers are quite similar. So it seems to us a bit more sensible to be giving it targeted in women that we know are carriers, while we're waiting for the vaccines to be developed. So if we have something that's better, great, we can stop giving penicillin. Immediate concern is, as of now, there are women in labour whose babies are going to end up with early onset group B strep, and what are we doing for them? And it seems to us that in the short term, giving something like penicillin briefly in labour to reduce the risk by, and we've heard this question, is it 70% or 90%? Might be worth mentioning here that the meta-analysis included all the studies of the effectiveness of antibiotics, including large numbers of studies which were criticised at the time when they were written up as using the wrong swabs, poor culture medium, leaving them in the fridge for 3 days before they were sent for culture, and so on. If you look at the studies which have been done which have followed best practice, we're talking much more in the region of 90% effectiveness, not 70%. And so I think at the moment, what we should be doing is actually keeping our eye on all these issues. So IAP for GBS, but also looking at the issue of erythromycin for ruptured membranes. I mean, there's a good case to be made for this past its sell-by date, and we should perhaps stop doing that. I am seriously concerned about the very large numbers of women being given broad-spectrum antibiotics for caesarean section. And the glib statement, no harmful effects have been shown on the baby, absence of evidence is not evidence of absence. So I think actually it's the duty of all of us to bear this antibiotic resistance thing in mind and go for what seems best at the time without ignoring the fact that there may be something better that we can do in the future.
I mean, I'm here as a neonatologist, and let me say first of all, I think it seems that we should agree with the conclusion that the current guidance is inconsistent, and that doesn't serve families well at all. The second point is that there is a great danger of the imposition of a consistent guideline when the evidence base is insecure, because of course you may well impose guidance that is in fact the wrong thing to do. So I think the imposition of a consensus-based guideline, in other words, a guideline that's not based on good evidence, is a really serious patient safety issue. And I'm going to give you a graphic example of that from neonatal medicine, which is that for years we used oxygen routinely, 100% oxygen routinely for resuscitation. That was considered best practice, and there was a great deal of dissent when people said, actually, hang on, this is a powerful oxidant and it might actually be doing babies harm. Roll on several decades, we no longer use oxygen for routine resuscitation. So I think as clinician scientists, if we're really concerned about the best outcomes for our patients, we do actually have to recognize that imposing consensus-based guidelines may well be extremely dangerous indeed. But where does that leave us then today? Well, it leaves us with, as I say, one firm conclusion, which I hope we can all agree with. The current guidance is inconsistent. It also, I think, leaves us with the position that there's a great danger in actually imposing something that may well be harmful. And therefore, for me, it seems that the self-evident conclusion that we have to draw, we have to reach, is that we really must stop trying to draw up guidelines on the basis of inadequate evidence, but instead put all of this passion, energy, effort, and well-meant determination to improve things for our patients towards actually addressing the science, doing the studies, and getting a sensible outcome. And if we had collaborated to do this 5, 10, 15 years ago, we would now have the answer. So I would like to say that on behalf of the Royal College of Paediatrics and Child Health, I am very, very happy to work with my colleagues in the Royal College of Midwives and Royal College of Obstetricians and Gynecologists to actually advocate and lobby in order to secure the funding to do the sorts of trials that we need to do.
Thank you, Nina.
I think you told us that the study proposal that went in and was rejected was around 11 million. So this is a time of austerity I think we would struggle to get. And I am very laudably accept Nina's kind offer, but I think getting funds and resources to do that study now would be quite a challenge.
Right, further comments. Dr. Rao, you mentioned earlier that you'd noticed that the baby's flora returned to normal. Do you want to...
I must hasten to add that it was not my study. It was a study that was published in the British Journal of Obstetrics. on gynecology. This was a study that was done in Canada, actually. This is a group which has been long interested in looking at microbiota of the mothers and the babies. In fact, just as a matter of interest for the obstetricians, that the fecal flora of the mother's vagina, so did I say fecal flora of the mother's vagina? I mean, the microbial flora of the mother's vagina actually changes during pregnancy, as does also the fecal flora. So I think without any antibiotics itself, you do find a change in the microbiota. The truth be told, this microbiota is proving to be a tool that a lot of people are using, and I don't know what to make out of it in terms of the veracity of the results, the implications of the results, whether one population of bugs go up and other population comes down, and how much is a natural phenomenon, how much is the drug-induced, is often quite difficult. That's one. The second thing which I just want to, as somebody who's been involved with the MRSA screening, and I say this with conviction, I mean, the MRSA screening, risk-based screening, was something that was advocated for many years by our Hospital Infection Society and all the august bodies. And every time, what would we find? That one, that those who needed to be screened would not be screened. You tried screening people, finding out the risk factors in the A&D department, which is heaving. Second, who is to ask those risk factors? Is it the nurse, the doctors, the person who actually does the swab? The third is that many people do not, a third of the, I can't remember what the figure that I published, it's something like 20% did not have the risk factors. So it's again the same thing. What I found by introducing a systematic screening, leave the antibiotic argument aside for the moment, cost-wise, effort-wise, operationally, it is far easier to have a system in place that, you know, like they did in the years gone by, paint everybody's tongues with gentian violet. The same thing we need to do today. If a patient woman is pregnant, she is offered the screening, and 35 to 37 weeks, once again offered, and if she's agreeable, do the screening and be done with it. This business of trying to identify the various plethora of risk factors, trying to, you know, the person who established the risk factors and the midwife who did it went off on maternity leave, and all sorts of things can happen. So I really do believe that a systematic way by which anybody can get into the computer, sees this lady is GBS positive at the time of delivery and gets the antibiotic, is far more easier operationally. A recent review that was done, which was commissioned by the Department of Health for MRSA, concluded, yes, there's some people more at risk of having MRSA than the others, but then they did said, there is an operational difficulty in identifying these people at risk.
Yeah.
And we come back to the square one, that today anybody comes to the A&D, if they're going to get admitted, they get screened, period. It costs a few bob, we waste far more money on lots of useless stuff.
How worried should we be that other NHS trusts are going to introduce their own screening programme in the absence of a national decision to do this? I mean, how dangerous would it be for little screening programmes to pop up all over the place? Nina, you're looking at me, so I'll ask you to start on that one.
And once again, Kathy, you read my mind, because I think that this too is an extremely worrying precedent. One of the things that this country has been known for is its very, very egalitarian approach to healthcare. We really do not want to go back to the days of a postcode lottery. And once again, not only do we want a we don't want a postcode lottery, but we also want to do the right thing for all patients. So I think you have read my mind correctly. And you know, I applaud the enthusiasm of the Northwick Park group, but I do wish that you had decided to implement a randomized controlled trial rather than simply introduce a new screening program. If you have introduced a new screening program, then what I would say, and you clearly have done that, and you've done it with great enthusiasm and great success, I'm not suggesting that we should turn the clock back, But I do encourage you to continue to evaluate what has happened, as you're clearly aiming to be, because I hope that you will be able to provide us with some interim answers. So I really encourage you to continue your evaluation.
I'm going to bring in Phil, because you were having a little reaction there, which means you're thinking something.
Yes, Nina, the way to avoid the postcode lottery, of course, is to offer every woman in the country the opportunity to know about GBS and decide for themselves as individual families whether they wish to undergo screening or not, given the benefits. Now, a lot of people always look askance when you suggest giving the patient a power to decide about their own health care. I've always been a lifelong believer that this is the right way forward. I think things are moving more and more in that direction. I think the Montgomery judgment was another move towards that. I think in future we will look back and be embarrassed about the amount of paternalism or maternalism that goes on in medicine. And I think that increasingly there will be choices which will need to be made by individual people about their health care, whether it's to have cancer care or, assisted dying, all these other things. I think patient autonomy will come to the fore. And in that regard, I'd like to pose a question, if I may, just one to the rest of the panel. And that is, while we have a situation where there is no national screening programme, we've already seen that more than half of units said that if women requested a test, which I'm told by the National Screening Committee is not screening because they're simply asking for their individual test, that 56%, I think it was, of units would agree with that. I am actually worried about the situation in the 44% where they would simply say no. What happens if that baby dies of early onset GBS disease and the woman has specifically had documented that she requested testing? And indeed, I can give you an example, and I won't mention the hospital, but I had a communication with the clinical director in one trust where if the women took matters into their own hands, literally, and sent off to one of the private units, had the swab, sent them off, and came back and said to their doctor, I am known now to be a group B strep carrier, they were refused acknowledgement of that finding and no recommendation for intrapartum antibiotics would be made. It seems to me unbelievable, but I promise you that's happened within the last 18 months in the UK, and I've got the emails to prove it. And I think that's an issue that perhaps we should all, so perhaps the question is, if a woman comes and asks you to be tested, what would you say?
Panel responses, please. Alan?
Yeah, it does happen. It happens not infrequently at clinics, and Andrew mentioned how uncomfortable you feel, especially when you chair the guidelines committee and I oversee it. You cannot turn that request down. But I'm disappointed by what Phil says. If somebody actually goes and pays for it and then it's ignored, that's appalling. It's unethical.
Alison?
I mean, I totally agree with Nina's aspiration. It's always good to have proper randomised control studies, but as part of the group that spent many a day poring through protocols and meeting up and talking and conference calls, and then there was a big collaboration which was led by Peter Brocklehurst, who some of you will know heads up the NPEU. And is an obstetrician by training. We were declined, and it was desperately disappointing. So, in the absence of that, we heard this morning there are pockets where Group B strep is encountered more commonly than others. Northwick Park was one of them. In fact, my own unit contributed quite heavily to the current BPSU study, and we're still considering, this is at Birmingham Women's, whether we need to adopt a screening programme because of the rate is above 1 per thousand. And we also know, thank you very much to the earlier speaker who talked about the study that we published in the Lancet from St George's some years ago, that culture-proven Group B strep sepsis is only the tip of the iceberg. It's probably double that incidence for actual disease, and this is where we know that it's very difficult to grow any positive culture in a baby, but if they have a CRP that goes from 1 to sort of 90 and they're sick, and they've got group B strep in their ear swab, then it's most likely that's the cause. So those were those sorts of babies. So I think that there are some positives, but if I was living in Scotland where the incidence is very low, I might not feel quite so inclined to support a screening programme. So it really does depend. I think we have to be cognizant of the fact that there are some areas where the rate is particularly high, and so for those women they're at even higher risk than others. And I'm not so sure it's such a bad thing to offer those screening empirically. But surveillance, in the absence of a screening programme, surveillance is absolutely critical in order to evaluate, just as Gopal's team has been doing. So that's just
Thank you, Alison. Now, I'm going to have to draw the panel to a close, but I just want you all very quickly, if you were walking into Ladbrokes this afternoon and you could place a bet on where we're going to be in, let's say, 3 years' time, will we have a national screening programme or not? 5 years. Okay, Andrew wants me to give 5 years. So in 5 years, right, starting with you, Andrew.
Yes, there will be a screening programme within the next 5 years.
Nina?
I'm going to say that if we put our collective efforts to it, we might have a trial done within 5 years.
Catherine?
Difficult to say. Possibly yes, and hopefully we'll be further along with the vaccine trials.
That's right. Phil?
My answer to when I'm asked that question is always you wouldn't want a gambler as your obstetrician.
Okay, well, I'll gamble and I'll agree with Andrew. I think we will have a screening programme in 5 years. I think these so-called creeping developments, I don't find them a threat at all, that what Northwick Park have done, as long as we get that data, because I think that will be supportive. Although it's not randomised trial data, I think it's still very useful data to inform the process.
Alison?
I don't know the answer to that. I hope very much we do. When I started working with Group B Strep and had the privilege of being asked to be on the panel as a paediatric advisor, I was absolutely terrified about the potential increasing use of antibiotics, and I was known as she who is against antibiotic usage. I now know from the data that actually if we had more solid information about whether a woman's carrying a pathogen or not, or potential pathogen, then actually it reduces the burden of antibiotic use. So I hope so. I hope we have a screening programme well within 5 years. But for me, it's and then I'll retire very happily. But it's watch this space.
Rao?
I'd like to just take up on what Professor Modi and I discussed while having a cup of coffee earlier this morning. Why can't we, and this is a proposal to the RCPCH and RCOG, and possibly RCPAT, who probably don't count for very much in this argument, is basically, why can't we try it out, universal screening, for a short period of time, and see how it goes?
So there's a proposal. Thank you, Dr. Rao. So